So an anticoagulant, and of course blood replacement if you're losing blood. It's a trauma that brings on, but it may be a gram-negative rod, and they give an anticoagulant plus something to fight the rod. DIC, we'll talk more about it. Now, what's left to talk about are, of course, the tests. We're going to start that next, tests. But what makes any of these problems? You know, I told you what is wonderful, and then I told you disorders. What makes the disorders? Well, we mentioned hereditary, trauma, chemicals can do it, drugs can do it, autoimmune can do it, infection can do it, antagonizing agents. All those things can throw our bone marrow into not acting properly, or throw our red cells, white cells, platelets to where they're not operating properly. The tests, and we've already talked about most of them, let's just list them. Schilling's, you all review that, intrinsic factor, 24-hour urine, and it's for pernicious anemia. Lymph node biopsies, the guaiac test, G-U-I-A-C, or the hidden blood occult blood tests that can tell if fecal material has blood in it. We'll know it's GI bleeding or whatever. So occult or guaiac testing. The Betz-Jones, we mentioned that, which is going to check our calcium and protein for multiple myeloma. D-dimer, didn't mention it, but D-dimer tells us if we've got a D-dimer rate, it's usually because we've got a coagulation problem. Of course, MRIs are used to check for tumors. CTs are big for checking our liver and our spleen scans. And you know, those lymph node biopsies I mentioned, especially for Hodgkin's and Reed-Steinberg and so forth. The differential is going to check all those 5 white cells. PT, which is prothrombin time, and what do we have on our card? 10 seconds on our laminated card. And then PTT, 20 to 40 seconds. I think we said 39 on our card. And INR, I think, what, 0.5 to 1.25 or 1.5, whatever your card says. I have some that I've used for years, but the card's fine. They're all close. Here's the deal. On INR or PTT, PT, any of those, if you know what it should be, if it's taking longer, then it's taking you longer to clot. That's the deal. If it's lower, you're clotting quick. And so something is going to make you clot, and we don't want to clot quick because that means clots. So whenever you are looking at these times, you need to do the thinking yourself. Ooh, if it's way up, it's taking me a long time, I'm bleeding too easily. That's what you're talking to yourself about. I think the term physicians say a control is what it should be, and what is your PT or PTT, and they say about 2 times, it used to be 2 to 3 times the control is okay if they wanted it that way. You and I don't want to walk around that way, but if they're fearful of a stroke or something, they want it 2 to 3 times that control. Now I notice physicians stop an anticoagulant when it's about 1.5 over. They'll give an anticoagulant, Coumadin, heparin, until it's about 1.5, and then they may stop it. They just don't want the person clotting, the whole point. Bone marrow aspirations are used. We look at CBCs and differentials. Sedimentation rate. I didn't mention SED rate, SED rate, or sedimentation rate. And it's high when an inflammation is happening. It could be an infection or just inflammation. I always think everything good is running to try to help, and there's a lot of sediment. That's the way I remember it. CRP is a precursor of sedimentation rate. A lot of people think CRP has to do with heart, and it does. So often we look at CRPs with the heart, but a lot of times it's looking at the inflammation of the heart, but it can also look at inflammation of other areas too. I just want you to realize, and that's most of the tests, that's not too many. What can increase, I talked about increasing clotting times, where they go higher, and aspirin can increase it, clotting times. When I say clotting times, INR, PTT, PT, D-dimer, all those. Aspirin, antibiotics. Sometimes meds can, like Aleve, Advil, Pepto-Bismol, and Excedrin, all increase our clotting time. You know that. You knew aspirin did that. Fresh fruits, peppermint, curry powder, prunes, they'll all increase it. Do I mean much? Not a lot, unless you're excessive. Now, some things decreased will make us clot too soon. And we don't want a lot of clotting too soon, just like we don't want to bleed out either. Antacids can decrease clotting times. Valium, barbiturates, oral contraceptives, laxatives, and then some foods like milk, eggs, broccoli, cauliflower, beef, pork, and spinach. Now, treatments, we've already talked. We've kind of interspersed treatments, but let's just list them. Transfusions, blood transfusions, platelet transfusions, plasma transfusions. You know what's in plasma. And let me ask you, if you do plasma, I might ask it, we'll talk about it in class, but if you're doing plasma, is it for the 98% water? Don't think so. Is it for fibrinogen? We can give fibrinogen by itself. Is it for gamma globulin? That's antibodies. Is it for albumin? We can give albumin by itself. Fibrinogen is really the reason. When I said we give it by itself, the real best way fibrinogen comes is as plasma. So we didn't need it for water. We didn't particularly need it for albumin because we can give a bottle of albumin. And we don't need it for gamma globulin. We can give antibodies. Fibrinogen really does best come in as the plasma. That's the main reason usually you give plasma. So if you have to give plasma at the hospital, surprise your instructor and be so good and say, no, it's for plasma. It's probably for my fibrinogen. Because you really, I said, it comes in a little bottle. It comes as the plasma. Another treatment are B12 foods, vitamin C, iron, folic acid foods. Then interferon, which is iron. And remember, interferon we give Z-Track, where you push the muscle over, give the injection, come on out, and push your tissue back over it, making a Z. So interferon or iron is done Z-Track. Heparin, we'll give that as an anticoagulant. Remember, if it's 5,000 units, probably it's prophylactic. If it's bigger than that, like 25,000 units in a 250 bag, it's probably because they have an active clot that we need to get rid of. Warfarin or Coumadin, W-A-R-F-A-R-I-N, or Coumadin. Aspirin may be given. Now, then 3 drugs. I want you to learn them good. Procrit, which is erythropoietin. It's in your briefs, I think. Sub-Q shot, about $500. It will boost the bone marrow to make red cells. It's also called Epogen. Epogen, E-P-O-G-E-N. We've got Numega, N-E-U, Mega. Sub-Q, $500. Boosts the bone marrow to make platelets. Then we've got Leukin, L-E-U-K-I-N-E, also called Neupogen, New, N-E-U, you know means white, Neupogen. And also the GSCF, GSCF, growth stimulating colony factor. It's just, again, sub-Q, $500, and it boosts white cells. Of course, we can give whole blood, but where do we give it? E-R-O-R for whole blood, because we want everything. But if we're in the upstairs oncology unit, then we probably just want the red cells. We don't need the plasma. Let's see if there's any more. Imuron, I-M-U-R-O-N, is an immunosuppressant. A lot of times given to try to keep antibodies down, push antibodies down, because they're attacking something, especially autoimmune. And I believe those are the medicines I want you. Desferal, we need that one. D-E-S-F-E-R-A-L, Desferal. And Desferal is D-E, like dehydration, dehydration, take out fluid. Well, Desferal is D-E Fersol, F-E-R-S-O-L, iron. D-E, take out iron. You know, when you get your red cells break down in 120 days, and we reuse the iron over and over. And if you get in transfusions through this blood problems, then your iron is building up so high, and they need to get rid of it because it's not good. So they use this drug, Desferal, and it'll get rid of the iron. It is P-O or I-V. Now, I want you to remember natural diuretics. We've got some more, and I'll bring them up in class, some more natural diuretics. But cucumbers and asparagus are natural diuretics. Teach the patients that. And natural antibiotics are vitamin C. And there's some more of those we'll look at. You can always, of course, Google too. If you're trying to teach your patient, just Google that as well. I think that's going to complete the lecture on hematology. But in class, we'll clear up things and hope have some fun. Okay?